Here, CEO and founder of Duke Spine Institute, and we're getting ready to perform our third surgery for the day. This will be our second laser surgery on the lumbar spine. Our patient has back pain, travels down his leg. He has herniations and annular tears at L3-4 and L4-5. There's a small one at 5-1. We're going to test that as well. So, again, back pain, right leg symptoms. What are his right leg symptoms? Numbness. Do we know? Numbness, tingling. And the reason I ask is every patient's symptoms in their legs are different. But there's 4 basic categories: numbness, tingling, weakness, and pain. That's it. Every symptom has to fit into one of those 4 categories. So we get different combinations with every patient. Okay, our patient's awake. I'm going to talk to him for a minute. Dr. Duke here, are you okay? All right, we're going to give you some numbing medicine and get started.
Pinch and a sting, John.
Yeah, a little pinch and sting. Just lay still. You're doing great.
John.
That's normal, John.
Numbing medicine, brother.
You're okay. You're okay.
John.
He's fine. He's just doing a little wiggle wiggle.
There's a numbing medicine going on there, John. Okay?
You're going to be all right. That's normal.
A little bit of numbing medicine. You're going to feel pretty sick. Next shot.
Yeah.
Okay?
Just lay still. Everything is okay. So we'll get started. So the primary, how are we doing on blood pressure? Good? The primary concern is L4-5 and L3-4 with a possibility of L5-S1 contributing. So we're going to be most focused on those guys as the pain source. We're on the right side. Everybody in agreement? Shot. All right, so let's go to a lateral view. So right now the needle is between L3-4 and L4-5. So I'm going to have to make an adjustment on my trajectory. Otherwise, you can see there's a little bit of scoliosis. All right, so shot. 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 Maybe it's moving a little bit, huh? Shot. That's on the facet. Nice. Shot. 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 Are you comfortable?
How you doing, John? You all right?
Shot. I think we're going to be fine here. Shot. I feel the herniation. Shot. Yeah. AP. Skin knife. Skin knife. Let me have it. Did I get you? Did I get you, Sam?
No.
Good. Okay, lateral. So that's, you agree, 4-5? Let's try for 3-4. Shot. Give me that 3-4 nicely. Num num. Take. Shot. Shot. All right, give me the lineup on those end plates. It's almost perfect, but try to give it to me just a little bit better. Shot. Is that it right there? Oh. Shot. Uh-huh. Very nice. Very nice. Shot. Uh-huh. Beautiful. Perfect. Shot. Uh-huh. All right, we'll need him awake. Not just yet. I feel the herniation. Shot. Yeah, it's right there. I can feel the tip right there. So the herniation is sticking out there backwards. Beautiful. So far, so good. We've made a 7mm incision. Let me see the knife blade. Make sure that's through and through. Try one more. Shot. You got to show me 5-1 now. Nicely done, Jordan. Nicely done. All right, that's hitting the facet or something. I need to back up. Go a little more lateral. Shot. 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 Just getting caught right on the facet. Perfect. Shot. I love it. Shot. Jordan, excellent work. All right, we need him awake now. Let me know when he's awake enough. Thanks, Luis. John, are you awake?
John? How you doing, buddy? John?
That was faster than I normally do it, so.
Got a sensory system. Doesn't take anything.
Oh, really? How much longer do you think we need?
It's straight focal. We didn't do anything else, so we should have quicker.
Okay, that's fine. But I'm very happy with the positioning. I just need some reliable data with his help. So, Sean, are you able to see here?
Hey, John?
For those of you tuning in, of course we can't hear Sean, but this patient has had chronic lower back pain right at the belt line. This is the belt line. And this pain that he's had has not gone away in time or with therapy. It's coming from some herniated discs in his lower back, specifically number 3-4 disc and the L4-5 disc. So L3-4, L4-5, quite possibly L5-S1, though I'm not sure about that. We're going to test it. Long story short, when we got the MRI, we saw that he had herniated discs at 3-4 and 4-5. And I knew based on where he was pointing on his back at the belt line that this had to be the herniated disc causing his pain. Now his pain is more on the right side going to the right leg, so we decided to go on the side that his leg symptoms are. Now look at this. This would normally, to fix back pain of this type, you have to make a big incision from here to here. This long. With a big cut, move the muscles over, take all the bone and discs out, put in cages, screws and rods. That's a major surgery. That's what most doctors do if they want to get rid of back pain from a bad disc, back pain and leg symptoms. So that's really the only surgery aside from what I'm doing, which I pioneered this surgery so that we could avoid having to do fusions. This entire surgery will be done through this 7mm cut. It's a Band-Aid incision. He's going to go home in 30 minutes to an hour after surgery. Is he awake? So he's getting close. So the reason I can get these these needles into the disc is I'm going through a hole that's already there. So let me have the dilator. Now, normally, to get to the disc, which is down here, Sean, I hope you're seeing all this and getting it. But you come through the back. The surgeon makes a cut in the back and you hit this bone back here. And the only thing you can do is remove the bone to get past the nerve and get into the disc and put a cage. Some surgeons go through the side or they go through the belly, much more dangerous. But the safest way to do this is through the back. You have to remove bone. But there's a way to do it. If you come off to the side at 45 degrees, you can go through a hole called the neuroforamen. And that happens to be where the nerves are getting pressed anyway. So you come in and you get into that disc and you can take care of the disc herniation and the annular tear, get rid of the back pain and leg symptoms without removing any bone. I didn't develop the approach, but I developed the surgery to fix the back pain. That's the Duke laser disc repair. So we're just about ready to get started. Are you comfortable? Are you comfortable? All righty. Shot?
Where you feel that, John? You feel it in the back?
How bad is it on a scale of 1 to 10? It may not be that bad because of the propofol. 9 out of 10 at 4.5. Is that better? Yeah. So when we inject the dye into a painful disc, it elicits the pain. It's called a discogram. I didn't create this procedure, but we use it. As long as it's done properly, it's very helpful. Yes, that hurts?
What about that one? In the back, John?
Is that his typical pain?
0 to 10, how bad was that? Huh? 5?
All right.
Is that worse than the first one or no?
It may not be. That's the one I didn't think was that painful.
5?
Yeah.
John, that one was a 5? Yeah.
Is that his typical pain or is that different?
Same type of pain or no? What?
So not his typical pain.
How much? How bad was that? 10?
Is that his typical pain?
Same type of pain, John?
L3-4 is 10 over 10.
Yes? Okay.
Is that where he typically gets it? Yeah, you can see the big tear there.
That was a 10, John?
All right, so
Yep. Yeah.
we're going to get started with 3-4. All right, you can go to sleep, John. When you wake up, we'll be done with your surgery and your back pain will be gone. Congratulations. Thanks for your help. All right, folks, look at that top area, that top disc. You see the dye in there? It's disseminated out through tears in the front and back of the disc. The tears in the front of the disc never cause back pain, ever. And they don't cause neck pain either. It's only the tears in the back of the disc by the nerves that actually cause the back pain. And the reason for that, and I've explained this before, is that the nerves that innervate the back of the disc is called the Sinovertebral Nerve. It comes off the nerve root, either the nerve root or the dorsal ramus. I can't remember which one, if it's before or after the ganglion. But it comes out and it basically goes and innervates the back of the disc. And it uses what's called somatic afferent fibers. So they go to a part of the brain called the somatosensory cortex, which is in the postcentral gyrus. It's part of the parietal lobe. It's the most anterior or frontal part of the parietal lobe, and it's basically got a little, like a map of the human body on it. So any kind of pain stimulation that goes to that part of the brain is part of the neocortex, or the new part of the brain. And that part of the brain is very sophisticated with respect to localization of pain. And it's really shocking to me that most neurosurgeons don't understand this stuff. They all think that this is back pain is poorly localized and that you can't, it's non-specific, but that's nonsense. It's actually very specific. And it's transmitted to that somatosensory, primary somatosensory cortex, so that's why patients feel that pain. Okay? Unlike the side of the disc and the front of the disc that travels via what are called visceral afferents. Shot? And the difference is visceral afferents don't go to the primary somatosensory cortex. They go to like more ambiguous, non-somatotopic organized areas of the brain, like the brainstem, the medulla oblongata, the pons, and the hypothalamus. How do I know all this? Am I just trying to sound smart? No, I actually am pretty damn smart because I'm a neurosurgeon, a brain surgeon. And brain surgeons do spine surgery. But unfortunately, not all brain surgeons use their brains. So they don't treat their patients with back pain properly. Shot. They end up ignoring their back pain and acting like it doesn't exist. In some respects, orthopedic surgeons are better at treating back pain than neurosurgeons. Why? Because orthopedic surgeons understand that joints that are damaged can be painful. Shot. And pain management doctors understand that. Anesthesiologists understand that better than neurosurgeons. So for being so damn smart, most neurosurgeons miss the boat when it comes to diagnosing and treating chronic pain because they're so busy unpinching nerves or unpinching the spinal cord. They just don't believe that people's pain, for some reason, they don't believe it's important or fixable. And I'm trying to change that. I'm like one of the few neurosurgeons in the world that are trying to change that perception. But the problem is they don't want to listen. They're unfortunately, too stuck in their ways. Something stuck somewhere. Where the sun don't shine, right, Jordan? Shot. I've gone and taught this surgery at the biggest neurosurgery meeting in the world, the American Association of Neurological Surgeons, the Congress of Neurological Surgeons, North America Spine Society. And yet people come and listen and they're fascinated with the surgery and what it does, but nobody calls me afterwards to say, hey, I'd like to learn how to do it. All right. I have no idea why, except I have some ideas as to why they don't. Because they're more focused on something other than fixing their patient. No one has ever called me except for one or two like foreign graduates from like India or China, and they want to learn. But as far as American graduates, it's extremely rare to get a phone call. Part of that is because unfortunately we're selecting the wrong people to become neurosurgeons in some ways. They're smart, but they also think that when they're done with their training that they learned everything they need to know. They believe their neurosurgery training is giving them everything they need to know to be a totally competent surgeon, but they're not. I didn't learn this in my training, and I went to the best. So if I went to one of the best neurosurgery programs in the United States and the world, and I didn't learn this, well, clearly they're not learning everything they need to know either. But nobody wants to hear they're going to a second-rate program. Okay, so we're inside the disc. It's a little hazy, but I think we're... Why am I so hazy, Luis? Wipe this? Wipe this? Wipe the tip? Yeah. Let's see. No one wants to believe that the training they had, the education they had was inferior. I mean, but the reality is that it is inferior when it comes to certain things. I'll give you an example. One of the diseases that neurosurgeons treat a lot is an aneurysm in the brain. And you would think that all the neurosurgery training programs, there's about 120 in the United States, that they all train equally well on aneurysm surgery, but they don't. To have a really good aneurysm surgery training, you have to go to a hospital that does a lot of aneurysm surgery. And that's not common. There's only a few in the United States that do a lot of aneurysm surgery. So if you go to a hospital that doesn't do much aneurysm surgery, like 10, 15 cases a year, as opposed to going to a hospital that does 300 cases a year, your training is going to be different. It's not like anesthesia training, right? For most of the time for adult anesthesia, you just have to be able to manage certain conditions and get a tube down the airway, blah, 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 blood pressure, And there is some variation, but with neurosurgical training, there's massive variation because some hospitals just don't perform certain procedures. So you're not going to get trained to do those procedures if you go to one of those hospitals. What I'm getting at, Grabber, is that neurosurgeons need to understand, and I learned this when I was interviewing. So I interviewed for neurosurgery programs back in 1995, and I interviewed at 12 different programs, including Harvard, Johns Hopkins, Columbia, University of Florida in Gainesville, Seattle, Barrow Neurological, all the best programs. One of the programs I interviewed at, for example, was Colorado Neurosurgery. That was like in Denver, Colorado. And it's kind of a funny story because it was not rated as one of the highest programs, but I wanted to interview there anyway because I thought I could go snowboarding and skiing when I wasn't working. So I figured I'd go check it out, right? But my advisor, Dr. Weiss, Dr. Marty Weiss, the chairman at USC in Los Angeles, who was the chairman of the Residency Review Committee for Neurosurgery, he knew the ins and outs of every program. He did not recommend that place, but I went anyway. I just never told him I was going. So I went there and I talked to their head neurosurgeon who does aneurysms, and I said, how many aneurysm cases do you do a year? And I asked for copies of their cases so I could see. I was doing my due diligence. I wanted to make sure wherever I went that I was going to get really good training. And they did 10 aneurysm cases the year before, which is nothing. I mean, it's horribly, abysmally low. Grabber. So had I gone there to that program, I would not have been trained well in aneurysm surgery. You can't learn with 10 cases a year. Enough. You need to do like 20 to 30 cases a year at least. So that program was not considered an A program. It was considered a B-level program. But can you imagine what a C-level program would be? Where you don't do anything, maybe one AVM or one aneurysm your entire 7 years of training, and then you come out and you try to take care of a patient with an aneurysm at a hospital that's bled, you're going to kill the patient, for sure. Oh yeah, at UF we have a lot of good we had a lot of good aneurysm surgeons. Dr. Lewis, you remember Steve Lewis from Australia? He was very passionate and very good. We had Art Day. You remember Art Day? We had Ho. Ho just started as I was leaving, though, I think. He and his brother, they both came just as I was graduating or just graduated. But the point is that the reality is your doctor, where your doctor went for their training has a profound influence on how competent they are at doing even the most basic types of surgery in their field. Stand by. So everyone thinks all spine surgeons are equal and that all the surgeries we do are equal, but they're not. They're 100% not even close to being equal. So don't fool yourself, because there's dramatic differences in our training. There's dramatic differences in our outcomes for surgery. And I'm not just talking about how well we cure your pain. I'm talking about the complication rates. That's the most important outcome measure, one of the most important in my opinion, is do you go have surgery for something and you come out and you're crippled, or your nerve is damaged permanently, or your esophagus is damaged permanently from a spine surgery in your neck. We had such a case a few weeks ago where a patient came to me that had an anterior cervical discectomy infusion at another facility, and the neurosurgeon cut through the esophagus during the surgery. Yeah, cut through it several times, and saw eventually as he was opening the neck. They didn't even do the surgery. He was just getting there during the exposure, and he cut through and saw the esophageal tube. So in his op report that he dictated, you know, he blamed the anesthesiologist. Unbelievable. I read it. He said it was a difficult intubation and the anesthesiologist was struggling and put the laryngoscope in several times, and that could have contributed to the esophagus being lacerated multiple times. Of course it wasn't the anesthesiologist that cut the esophagus, it was the damn surgeon, and he was already thinking of how he could blame someone other than himself. Okay, and that's in my opinion a piece of shit. Okay, and there's a lot of piece of shit surgeons out there. There's a lot of piece of shit doctors out there. A lot. You would never hear me say this 20 years ago, because I grew up believing that all doctors were like my father, noble and honest, competent, forthcoming, open, engaging, charismatic, and caring about their patients, and very intelligent. Unfortunately, the doctors are intelligent, but many of them are very incompetent, technically. And I didn't realize just how incompetent neurosurgeons could be until I was in neurosurgery training. And I saw it firsthand. Surgeons just making mistakes with their hands, just knowing what the right thing to do is, but their hands don't cooperate, you know? And I grew up playing sports my whole life, so I was pretty good at hand-eye coordination and doing things like that, but I assumed everyone else in neurosurgery and orthopedics was as well. But then I started seeing things happening to patients during my training that was shocking, that people could make such mistakes. When I mean people, I mean surgeons. So the reality is that if you're out there getting medical care and you don't have a good surgeon doing your surgery, there's a very good chance they're going to mess up and hurt you. And of course they'll blame someone other than themselves for doing it. Now the surgery you're watching right now, the laser surgery I'm doing, we've done over 1,100 surgeries and we've had 0 complications. In, how many years has it been? Bless you. I think I started in 2006, so it's 14 years. 14 years, over 1,100 of these surgeries that you're watching right now and on the neck, 0 complications. A complication would, in surgery like this, would include nerve damage, permanent nerve damage, spinal fluid leak, death, paralysis, infections from the surgery. None of those things have happened. Every patient has a cut, of course. A cut is not a complication, that's a surgical incision. A recurrent disc herniation where they blow out the disc a second time is not a complication. It's a recurrent disc herniation. Something different. We don't count that as a complication. This disc is pretty badly damaged. How old is our patient? Stand by. 70 something. And look at this disc. You could find this disc in a 25-year-old. His discs are quite well preserved. The only problem is that tear that's causing all the pain. Laser. We have a question, it sounds like. All right. I can't hear. Sorry, Sean, just hold on. We need to turn the volume up. And I apologize to the audience. We had a processor blowout on the voice command side of our system last week, and we've been waiting for the part now to get it repaired. So when Sean asks me questions, he has to call into the operating room on the phone and ask me those questions. So bear with us. Let's turn the volume up on the phone. Ask again. Oh, that's a great question. So our viewer is asking, Dr. Deukmedjian, I don't understand. Why do some people get small herniations with lots of pain and other people get huge herniations with no symptoms at all? The answer is simple and complicated at the same time. The simple answer is that the disc herniation that has inflammation from it will cause symptoms. The disc herniation that doesn't have inflammation won't cause symptoms. Now, all disc herniations, 100% of them, come from a tear in the annulus first. So all disc herniations have some degree of inflammation. And the truth is that most of the time your body heals the herniation. It's still going to be there, but it heals it so it's not painful anymore. And that means the inflammation is gone. So basically our discs are capable of being healed to where the herniation is still there, but the inflammation from the herniation is gone. Okay? That's the answer. That's why. Only herniations that have inflammation are painful. And what I found is that the inflammation happens right here in this tear. Something is on my right eye. Hold this. Can you check, please? I think it's the tape is coming up or something. See on my right eye there? Is the tape popping up?
Yeah, it was.
It's irritating my eye. Yeah, it's better. Can you push it harder?
Yeah.
It's still tenting up. Push really hard. I don't care. You're not going to hurt me. Yeah. Wow. I was getting like a jet of hot air every time I was talking.
Ready?
Right to my right eyeball. And it's tearing me up. Sorry, Luis. I'm not crying over you. So the answer is the size of the herniation makes no difference. What matters for symptoms is inflammation and how much inflammation there is. All right, it came back again. I'm going to need you to push it in again in a minute. I'm just going to shut up for a minute and try to get some work done and not irritate my right eye. This is the last of this herniation right here. We're just at the end of the annular tear. What you're seeing at 12 o'clock right there, that white stuff are the fibers of the posterior longitudinal ligament, really lateral, kind of the foraminal component, where it becomes the foraminal ligament. And a little bone spur right there where I'm zapping now. The herniation is where that hole is that I zapped away. It's gone now. And the way the laser works is it breaks these big chunks up into little pieces. And you see how it just floated out? As these pieces come up the tube, they're actually leaving the body. They're leaving the patient's body. Well, if you're in the Indianapolis area this weekend, I will be there with our driver, Arius Deukmedjian, who is my son. And he's been driving race cars for Duke Spine Institute since he was 7. We're going to be at the Newcastle Motorsports Park in Spiceland, Indiana. So if you're in that area and you want to drive down and say hi, come on by. Newcastle Motorsports Park, and look for Dr. Duke. Everyone out there knows who I am. For the most part, they'll send you my way. And we'll introduce you to the driver and you can watch some racing. These are the best drivers in the United States racing this weekend to wrap up a national championship race series. in Indianapolis. Arias will be racing on the Willpower cart, named aptly after Will Powers, the IndyCar driver. All right. Let's just see lateral. Wrap some of that up. Just about done here at L34. Remember, when you get real lateral on the herniation, which is where we're heading out now, you don't get any pain, because the lateral part of the disc it has visceral afferent innervation, and visceral afferents don't create the kind of pain that you can feel, sharp pain. They don't create sharp pain at all. This is the last of it. We'll be done in 10 seconds with this level. Laser off. And I'll show you the nerve is up here. A little bit of fat around it. You can't really see it that well. Well, let's see. Well, wait. Let me grab that. Let me have the grabber. Make sure that's not a piece of loose disc. Yeah, I'm starting to fog up my glasses. I'm gonna need to do something with my mask. I cannot take the tape off. It'll fog up my glasses the whole time. I need the laser again. I want to get a little bit more of that. Yeah, you can put another piece of tape. Okay, guys, come on. Don't pull on this. You have to have a system of winding that up. Okay? You ever seen those commercials on TV where they have a device to wind up a hose when you're done using it? Huh? You have? Why do they have that device? Huh? To do what? To organize the hose. Why are there so many devices manufactured to organize hoses? Because it's not an easy thing to do, right? So you guys have to develop a system that makes it easy for you to use the laser fiber and take it out and put it in. All right, good job. That was I think L34, right? Are you ready for my mask? Okay, put some pressure here. Maybe take off my glasses.
Sorry if I'm pushing too hard. Does that feel tighter?
Yeah, it's good. Nice, Sam. Thank you. Take this guide wire. Oh, L5S1, by the way, was discordant. Shot? Discordant. Not as typical pain. Shot? And it was a 5. Okay, let's get this done. Dilator over the guide wire. Just lay still. Shot. I think this is, if I'm not mistaken, this is 4-5. Was that the more painful one? Yeah. Shot. Shot. You're doing great. Just lay still. Shot. I need the hammer still. Take. Nope. Shot. All right, that's good. Hold that. So now we're going to put the tube. This is what we're doing the whole surgery through. Is this? It looks like a metal straw. Lay still. Lay still. You're doing great. We're almost done. Shot. I know it looks brutal putting it in. Shot. You're fine. Shot. We're almost done. All right, let's remove the dilator. Shot and fluoro out. All right, let's get the fluoro out. It's coming again. I don't know why it's tenting.
You think this side?
No, the side is going to pull it up. Remember, there's a natural valley there, so if it goes straight across, it's going to create a hole. You want to push it in right in the valley.
So I'm just gonna kind of redo the whole thing.
That's fine. Let's try that. Alrighty. Watch the grabber, guys. You can't just leave it here like that until I get all this hooked up. Oh. Just lay still. You're doing fine. We're almost done. Just lay still. Don't move around. I think it's in a little. Alrighty. So we're inside the next painful disc, which we know is causing his pain because he told us when we tested it. And there's the herniation. Try to get some of it out with the grabber, but you see how relatively ineffective the grabber is at getting there. We could grab the nice piece there. The grabber is good at pulling big pieces out once they've been released, but the laser is really the most effective tool. So people laugh about using a laser, but as we talked about earlier, the laser is a very valuable tool in medicine. It's finding more and more use. It's been around for a long time. Not as long in neurosurgery as it has been in urology, which are the kidney doctors or general surgery, even ophthalmology. They've been using lasers long before neurosurgeons.
No, I just gave you something else to clean, right?
We've got about 5 more minutes left, maybe 10 max. There's the tear. Now our surgery is not taking the whole disc out. We're just repairing the part that's torn in the area that's causing his pain. So we're not repairing all the tears on the disc because there's tears all the way around the disc. As I said to you before, it's not all the tears that are causing his symptoms. It's just a tear in one specific area, and it can be on both sides, left and right. But in his case, it's primarily on the right side that we're dealing with pain. The right center of the back. That's been confirmed by these two discs being positive with the discogram for his typical pain. But don't think that I'm operating on, oh, there's a big piece of herniation right there. Standby laser, take it, grab her. Yeah, the disc is just, this blue stuff is called nucleus pulposus, and it itself is not painful. The white stuff is where the pain is coming from, but the blue stuff is what's making it painful. Think of the blue stuff as being like a splinter, and the white stuff as being the skin around the finger where the splinter goes in. It's the actual white stuff that's hurting, but it's being hurt by the blue stuff. The blue stuff is the herniation part. So it's really not the herniation that's painful. Technically, it's not the nucleus pulposus herniation that's painful. It's really the annulus that's painful. And that's what my discovery is that has really revolutionized the treatment of back pain from a herniated disc. That's my contribution to the field of back pain and neck pain. Same thing happens in the neck, by the way, if you're wondering. These annular tears, herniations, and pain, they don't just happen in the lower back. They happen in the neck, just more common in the lower back. Unfortunately, a lot of people think that the pain, they just have to live with it. There's no fix for it. We get that all the time, but the truth is it can be fixed. As long as your surgeon knows how to do it. Most surgeons don't. Like I said earlier, anesthesiologists that specialize in pain management know more about sources of back pain. Physiatrists that specialize in pain know more about back pain. And the anesthesiologists, the physiatrists, than most neurosurgeons and orthopedic surgeons. So, however, the solution here is a surgical solution. So until we can connect the solution with the source, we're going to keep having a lot of people unnecessarily suffering with chronic pain. All right, I think 5 minutes. We should be done. This is pretty interesting. The disc is pretty well preserved. It's got a lot of disc material. Usually at this age, people's discs have dried up considerably. They don't have a lot of material. Yeah, just lay still. You're okay. Almost done. Stand by. Grab her. Yeah. It doesn't feel good, that energy being delivered to the annulus. I took a pulse once. I just dropped it. I took a pulse once right to my finger because the fiber cracked, went right through my glove, and within 1 or 2 bursts it almost went out the back of my finger. I have a scar on my index finger from a laser. I was in the very beginning days when I was learning how to use the laser, and I made the mistake of twisting the laser fiber too hard suddenly, and it cracked the laser fiber, and I stepped on the pedal, and I didn't know it was cracked when I stepped on the pedal, but it sent a jolt right through my finger. It literally felt like I was being electrocuted with a 220 volt wire. Okay, thanks. And there's the end of the tear right there. Yep. Okay, you got to change that you ought to change the irrigation when if you see that you're going to need to change it, you should change it when I'm actually putting the next dilator in. When I'm not using the laser, okay? Otherwise it dries out the whole field and then it creates problems. So do you understand what I'm saying? Keep an eye on the irrigation. If it looks like the bag's going to need to be changed soon, change it when I'm actually putting the next dilator in the next level rather than when I'm actually using the laser. When I'm using the laser is when I actually need the irrigation. And that literally completely dried out the entire tube for a few seconds. So I want to try to avoid that going forward. Normally it's not so bad, but for some reason it was just really bad. Yeah, there is no other surgical instrument that works like this. You couldn't do this surgery without the laser. There is one other tool that some doctors use during endoscopic spine surgery, and it's plasma energy. It's otherwise known as radio frequency. Radio frequency probes can generate a lot of energy, but not as much as the laser. And the laser is much, much better. But you can use a little radio frequency probe, but you'll be here all day. Literally all day. So the laser is far better. Just about there. 2 minutes. We found where your pain's coming from. I'm sure you're aware of that.
Done. Done.
Is he okay? A lot of scar tissue, by the way, right here. Not the blue stuff. The blue stuff is the nucleus pulposus. But the white stuff, real thick stuff that's taken forever to go away with the laser blasts, that's all scar tissue. 30 seconds.
We have one more to go, right?
Yeah. Why?
No, I just want to make sure.
You want to make sure I know that?
No, you know it.
You know, I know. Oh, yeah, yeah. You're doing great. We're almost done, buddy. Any questions there before we wrap this up, Sean? There's the end of it. You can see the posterior longitudinal ligament. A little bit of calcium. Now we do video and broadcast all of our surgeries for educational purpose to teach the public about the most advanced spine surgeries available in the world. You saw, if you were watching today, we did an anterior cervical discectomy and fusion earlier. Now we've done our second Duke laser disc repair endoscopic surgery of the spine. And we've got one more to go. It's a single level. And we'll be done for the day. If you have questions, feel free to ask them. Grab her. All right. Looking good. The nerve root's going to be right up there. You can see it's virtually bloodless surgery. Only a few drops. Scope off. All right, you ready? Wait, watch the needle. Take that. Take that.
Take a deep breath in, everybody.
Take this. Yeah, we're done with this. Yeah. Okay, thanks everybody. Good work. Is that the last one you were talking about, Luis? Oh, no, yeah. Discordant. I don't think it needs to be done. Okay. Good work. You got a Ray Tech off the field. Any questions, Sean? I'll head over to the conference room and answer any questions. If you've got them, type them up.
All right, everyone. Thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us, ready to take some questions. We only have one question so far. One of our viewers on Periscope is asking, what is the difference between Duke laser disc repair and a laser discectomy? I believe they're referring to PLDD.
Okay, well, thank you for asking. There is a difference between Duke laser disc repair and laser discectomy. The main difference is in the technique. So the technique for a percutaneous laser discectomy, it's typically done with a needle and just a needle. So if you remember watching the entire surgery, we started with a needle, but we didn't end with a needle. We ended with a surgical incision, then a series of dilators and tubes, and then an endoscope. So the classic laser discectomy, percutaneous laser discectomy, used to be known as the IDET. That is a procedure done blindly with a needle going into the disc, and then the stylet comes out and a laser fiber is put down that center of the needle, and the surgeon just hits the pedal for a few seconds or a minute, and they just zap whatever's in the needle or the path of the needle, and they're done. What we did was I brought the actual scope and the tubular retractor. I brought the surgical field inside the disc, and I cleaned up the entire annulus, debrided the annulus. You can't do that with a laser discectomy. There's no annular debridement being done with a laser discectomy. The annular debridement is about 95% of what I do, and a discectomy represents about 5% of what I do. So two very different procedures. The most important is the method that the procedure is done. The laser discectomy is not a surgery. It's usually a needle procedure done by pain management doctors. Takes a few minutes to do. The Duke laser disc repair is an endoscopic procedure, and it's an annular debridement. 95% of annular debridement. 5% of the time is spent on discectomy. So very, very, very different procedures. I hope that explains it. If not, feel free to ask another question. I'll try to clarify it better. Do we have any other questions? All right, we do have one more surgery to go. It is going to be the same kind of surgery, the Duke laser disc repair, endoscopic procedure, and it's on a L5-S1 disc herniation. Our patient is a young man. He's thin. We're going to try to get into that L5-S1 disc space, and we're going to perform the same procedure. We're going to clean up the annular tear so that it will heal properly. That's the biggest thing that gets rid of the back pain. And then we're going to remove the herniated nucleus pulposus using the laser and pituitary rongeur so that the annulus will heal properly. And that will get rid of the back pain and the leg symptoms. Okay? We're going to have that started in about 25 minutes. Thanks.